Thank you. Thanks for having us. We're happy to be here to talk with you. We'd love for it to be interactive as we go through. I know you probably have questions maybe about what we can offer, or as a county board, or in general. We really want this to be information that is helpful to you. So if you help steer us with that, that'd be great.
And you guys are the lucky ones, because you get to see us live. The people who are going to be watching this on recording, we're going to see a much heavier version of me because the camera adds 20 pounds. So, congratulations to you. We both do supervisory work at Stark DD. We work with the SSA department. SSA stand for Service and Support Administrators. And have any of you had an opportunity to work with any SSAs? Okay.
Are there some of you who have not? And do you all know kind of what it is and how the county board is set up? And no. Okay. So maybe, do you want to start with that?
Yeah, go ahead.
We can start with that. Okay. So Ohio is unique in the country. Every county has its own county board of developmental disabilities. And we all follow the rule. There's Ohio Revised Code that kind of dictates what we do as a county board. There are a couple mandated kind of things. Service and Support Administration is one of them. And we'll go into a little bit more detail about what Service and Support Administration does. But just to kind of give you an overall, generally what we find is people in the community, when you say Board of DD, used to be Board of MRDD, what do you think about? They think about the workshops. That really was kind of the face of our agency for a very long time. We are no longer a provider of that service. So our workshops, we no longer have workshops that are run by the Stark County Board of DD. You might be aware that there's two large buildings, one in Massillon, one in Canton South. Those buildings still exist, and there's still folks who go there, but it's a different provider now. TWI is the provider of that. So we as a county board are no longer involved in that. And that is because of the Medicaid tenant that for not being able to write the plan, which is what SSAs do, and then provide the service that that plan authorizes. So the Medicaid says we have to split that up. So that's where that came from. That's across the whole state. Some county boards have been separated from their services for a long time. Some still have them and are still working on separating that. So most of what the county board does now is ensure that folks get the funding that they need to pay for the services that help support them to live in the community instead of living in institutions. That's kind of like the easiest way of saying it. We also do still in our county operate 2 schools, and early intervention is another one of the mandated services that the County Board of DD provides, and that's connected to our preschool as well. So,
what is TWI?
So that's a really good question. We've never been able to answer it. Here's kind of, I'll give you the gist of it. So it stands for the Workshops Incorporated. That's where TWI comes from. Okay. TWI used to be the private, can you explain this? Because I could never fully grasp it.
I think it used to be, they used to have a couple of employees at the county board that was employed by TWI. They created a separate entity, I think, to be able to have some, for tax purposes whenever they were operating the workshops. When they separated, they just kept that name, TWI, because it was already kind of branded. People knew it, recognized it. So now it's just a private provider known as TWI. Still would be titled the Workshops Incorporated, but no affiliation with the county board anymore.
Right. So when we say private provider, there are well over 100 providers in Stark County who provide services to people with disabilities and then bill their Medicaid waiver. TWI is just one of those. It's a large company. The providers go from being quite large to independent. So as an independent person, I could contact the Department of Developmental Disabilities and get certification to be a provider. And that means I can bill the waiver as I provide services to the individual. That can include services in the home. It can include transportation. It can include services in the community, somebody being with someone in the community so they're safe and get their needs met. It also includes day services. So we're very careful not to call it work anymore. There's a lot of federal kind of pushes going on right now too that drive us to really try to keep people working in the community, get them out there working in the community as opposed to being segregated in workshops. So.
Any questions about any of that?
So we have about a little over 100 employees in our Service and Support Administration, which has increased dramatically. When Justin and I first started over 10 years ago, there were 20, maybe 20 people, 25 people. So the great thing about that is we're getting more people out of institutions and keeping them in the community. So.
Stark County serves roughly 3,900 individuals with developmental disabilities. So. All right, so we're kind of going to look at the agenda here as far as kind of 4 categories. 5 things to know, information to gather, interactions and approaches, and then looking at diagnosis, some interventions. And then at the end, there's some additional resources if you want more information on that kind of thing. If we've got some time at the end, we can also talk about eligibility, a little bit more specifically on how you become eligible for county board services, and possibly some of the behavior support kinds of things, because at times, things that are recommended by counselors or medications that can be prescribed can also butt up against state rules that we have in our system. So, if you have questions as we go through, please feel free to ask. So 5 things to know. One is that the DD system has a team orientation. So we focus on teamwork and kind of gathering information from a group of people. And we put up some definitions here. The team is anybody who the individual wants on that team. It can be a counselor, it can be a guardian, it can be the providers that Rose mentioned. Sometimes there's neighbor, friends, whatever. Natural supports are those unpaid people who support that person. And it might be, hey, they just drop in and say hi to them. Or they take them to the ball games, whatever those things that they are. The individual service plan is the document that kind of drives all the services that are provided for the person. So, have you seen an individual service plan here? Okay. Now, for your purposes, some of that might not be as helpful of information because it's telling the provider what they need to work on and what they need to help that person with. But some of the information could be helpful to you because it does include some diagnoses in there. There's a section on medical, section on pretty much all the domains of life that we're looking at. So while you might not need to know exactly the routine in the morning of how they get up and get dressed, that kind of thing, you might need to know medical issues and supports of that nature.
Right, and on top of that, especially for folks who have some more challenging behaviors, in our plans we try to put in how to best support the person, what works for that person, maybe what doesn't work for that person, likes, dislikes, that kind of thing. So those are things that you working with someone might find helpful as well. Yeah, the rule has that's 2 components. What's working, what's not working. The rule says we have to include that in their plan. And important 2, important 4. So something might be important to a person that they would like to have happen in their life, but then there might be doing things that we need to make sure we support them that's important for them. So one other thing I want to bring up, the team approach that the Board of Developmental Disabilities uses, in my experience, is different than in a mental health system where you're working typically with an individual and maybe not so much their family and their supports. I know everything's case by case, but again, by rule, and which is we have a lot, I know you guys probably do too, we have a lot of rules. Someone is eligible for services through our board, then they require a team. It has it right in the definition of eligibility for a person with developmental disabilities. So that team approach is taken very seriously in our system. And the reason I wanted to make sure I brought that up is just to kind of let you know and be aware of, You may be getting a call from a parent, and then you might get a call from a provider, and then you might get a call from an SSA, and you might be thinking, why are all these people calling? The best way, what we found to do that, is to kind of have a discussion, and we try to train our SSAs on this, that there should be one contact person, because it's too confusing to have so many folks calling. But I just wanted you to be aware that that is one of the major differences, and that's why you might have so many folks calling you, asking.
And the SSA is the primary point of coordination. So they're supposed to coordinate all the services for the individual and kind of keep the team on track where they need to go. All right, so number 2, the SSAs are not case managers. So there are some clear boundaries that we have to follow. SSAs cannot provide direct service to individuals. That's probably one of the primary. They're going to coordinate the services, but they're not going to actually perform any of the services. I don't know anything else.
That includes not driving somebody. That, transportation is a huge issue. I'm sure when you work with folks that comes up for you. It comes up for us a lot. We work with people who have a funding source through a Medicaid waiver, but we also work with people who do not have that funding source. And then we need to look into the community, much as you do, to see what's available for a person, what they can afford, what they might already be entitled to. So.
As we've mentioned a couple of times already, rules define the scope of practice and the limits with which we can perform. Person-centered planning is a big focus. We've got to make sure that we're focusing on what the individual wants, what's important for them. The behavior support rule is another one that I mentioned earlier. Has to focus on risk of harm or likely legal sanction in order to be able to do anything that would be considered a restrictive measure for a person. Then there's the prevalence of trauma. In the DD system, that's another thing that I know we're kind of focused heavily on, is trauma-informed care. And I know mental health also has that focus. We see that from the state. Both departments are joining in efforts of that.
And the hopes with that too is that then we're going to share some terminology through both systems so that we know what the other person's talking about.
And at Stark County Board, we also have some people who have been trained on trauma-informed timelines. So we're able to do those for individuals who have experienced significant trauma. In the DD population, it's likely that as much as 90% of the population has experienced trauma or abuse in their lifetime.
And then we use that information that comes from the trauma timeline to educate us about what interventions or supports we need to write into their ISP. So if you get a plan for someone who's here, you might see some information about their trauma background and what information came from the timeline.
Also in the DD system, all of us, SSAs, county board employees, providers, we're all mandated reporters. So if we hear that somebody's been abused, neglected, anything of that nature, we have to report that, which can also make that statistic higher, potentially. And our services are voluntary. That's probably one of the biggest things. Sometimes people think that because you have DD services, you have to have DD services, but individuals, they are free to accept them or to not. If they have a guardian, that might make it more likely that they're going to have to accept them because the guardian wants it. But it also poses some unique challenges for us in trying to deliver services and coordinate services, because if you get somebody who does not want something and you're trying to force them to have it, you get a lot of challenging behavior in return.
Right, especially when there's a lot of risk involved. That's when too we reach out, usually to mental health too, and try to come up together with some kind of plan for a person. If they're completely cooperative, we do have the means to have 24-hour staffing if they need it, and to set up their environment potentially in a way that might make them a little bit safer. But if they're not willing to accept that, there's very little that we can do.
Thoughts, questions, comments, anything?
Dr. Duffy, Dr. Kimball, are we getting these ISPs from outside?
We're doing more to get them currently, yes. We have tried to find contact people in the different counties. That's the challenge, is that having different counties that we work with, knowing points of contact, who the SSAs are, and then getting those documents. But we have, with the last few that we've had on our unit, we've been able to get the individualized service plan.
Yeah, I think for Stark County, usually Stephanie either contacts Rose or myself, and then we help with getting that information. On the ISP, it identifies who the SSA is as well. So some information to gather interactions and approaches. One of the things is finding out if there is an SSA, because that's going to be the person that's going to probably should be your main contact. They should be assisting with coordinating with the providers of care after discharge from Heartland. If there's a guardian, you'd probably want to know that too, because they're going to be the ones that get to authorize, medication changes and medical treatment. And the providers then. So is there a plan for what happens when a person comes out of Heartland? Sometimes we have situations where we have to find a new provider because of whatever the issue was that led to the hospitalization may have made that current provider unwilling to continue to serve. So then we need to find a new provider, and so at that point, that might take a day or two to do that, to coordinate that services. We also want to make sure that if there's any kind of interactions and approaches that you all have learned in working with this person, if that's something we can translate to the ISP to help support the provider, whether it's a new one or an existing one, in better serving that person and hopefully avoiding any further hospitalization.
So, and depending on how long the SSA has been working with the individual, the way that we train our SSAs is they should be the best contact person for that person. Generally, SSAs know their individuals really well. They may then direct somebody to somebody else who has some information they don't have. But generally, you should be confident that if you're talking to the SSA, that you're reaching the whole team.
And on that slide, I don't know if you can see it on your handouts, but at the bottom, it kind of identifies the three main categories of providers. HPC is homemaker personal care. That's a provider who's going to do stuff in the home and take people out into the community. ADS is adult day services. So that's going to be people who are working with folks in day settings. So we're looking at job development skills, looking at building social skills, whatever those things might be that they need. NMT is non-medical transportation, so they're helping the person get to and from work to home. Does the individual have an About Me, For Me assessment, the AMFM is what we call it, and an individual service plan, the ISP? Now, this is what we were talking about a little bit earlier, and you said you're trying to coordinate contacts with different counties to see how you can get those. Sometimes these are very lengthy documents. The AMFM especially can be very lengthy. In Stark County, we include both documents. The AMFM kind of identifies more specific what's going on with that person. The ISP is a little bit more generalized, a little shorter, and it's going to direct these service providers to do these things. The state is working to create a unified plan for all 88 counties, because if you see Stark County's plan, you just see Stark County's plan. So there's 88 counties who have their own version of the ISP and assessment process. So the state's working on creating just a one plan for everybody.
So that's a good point too, because then if you're working with a county different than Stark, you're going to be getting a document that looks differently, and just to be aware that it might still be at the service plan, even if it doesn't look like the one you get from Stark.
You logged into another device, so I am logging you out of this one.
So,
Okay.
one of the things that can be helpful in the ISP is towards the back there's a circle of support. Circle of support lists all of the providers that are going to be supporting that person. It also lists the guardian if there is one. And the demographic information included in there has the information for the individual, where their address is and birth date and that kind of stuff. So communication. We talk about behaviors primarily being communication. I know sometimes we get into that issue of, is this a mental health concern? Is it a symptoms of their mental health coming out, or is it behavioral issues that are being manifested? And sometimes that's hard to identify. But we know that oftentimes when people are experiencing distress, they're going to act out in ways that have worked for them before to get what they want. So we look at all communication as an identifier of what that person's trying to do, and whether or not they can verbally tell you, hey, I'm feeling sick, hey, I've got a toothache, hey, whatever, or they're hitting themselves, they're being aggressive to others, they're telling you something's wrong with them at that time. And usually the team that's working with them, especially the providers, they know that person and they can identify when this is not their typical behavior that they do, right?
And just to add to that, I think there's a myth. In fact, I know there's a myth sometimes that people think that someone with a developmental disability is always going to have behaviors, that it's just part of who they are as a person. And the truth is that that's not accurate. Anytime a person, as Justin said, is exhibiting some type of behavior, if it's not related to a mental health, if it's not a mental health system or symptom, then it's some kind of communication. There's something wrong. So you will find that those folks that have a harder time communicating tend to have more likely to have behaviors that are challenging for people working with them.
So I can't see the little print anymore. Not everyone has good verbal communication, like I already mentioned. There are other types that we can look at. There's sign language. There's facilitated communication that's helping somebody by using, like you move their hand to direct them to letters that they might be trying to spell out something. There's also picture boards, so they can point to an icon, a picture. Sometimes people have like key rings with laminated photos that they can use to communicate what they want. Word boards are same kind of thing as picture boards, just pointing out to the words. Electronic devices, so with iPads and with those kinds of different Kindles and the tablets, people can use all kinds of supported communication. I know there are apps that are also available that can help translate. So you can look at translating words to sign through an app if you don't have a sign language interpreter. There are also some apps that will connect you to somebody who on the other end can then do like FaceTime and do that translation for you. Have you ever had to work with anybody who's had to use some sort of facilitated communication device? So interactions approaches, displaying calm body language, giving people personal space, using positive tones and words, space. Introducing yourself, letting them understand your role. It could be a new situation for some people. It might be intimidating, might be scary.
And
so,
I'm sorry. I was just going to say, there's a lot of people that you'll meet that have a lot better receptive language. So they do understand what you're saying, even if they can't share with you. So I would make that assumption that they can understand what you're saying. Being clear, using simple words, kind of being very concrete. Speaking clearly, repeating and rephrasing if you need to, because sometimes you might not understand, so you might want to check in for that. Avoiding jargon. I know in the DD system we have a ton of alphabet soup and jargon that we use, and I know mental health world has it as well. So trying to make sure that we're using simple terms with people to help them understand. Allowing extra time for responses. Just because they don't say something right away doesn't necessarily mean that they won't say something or they're not trying to process that information. And that one, I would say out of all of these, I've found is the biggest one. When I attended a first responders training a couple years ago, there were some firefighters there who were going through the training. And that was the comment that they made, that it's so simple. They're so used to it, and police too have to make decisions real quickly. You may have to make decisions really quickly, and so you're trying to elicit information. So that's what they said, if I just give a little bit more time. So that was a really big one for them.
Giving praise and encouragement. Let the person know that you appreciate what they're trying to communicate to you, that you're helpful, that you're a positive person to be around. Checking for understanding, so making sure that you understand what they're trying to say to you and what you're trying to communicate to them is being heard. Just doing that rephrasing. So is this what I hear you're saying? Have I got it? Checking your understanding too. Interventions, diagnoses. Developmental disability is a severe and chronic disability. It's attributable to mental and or physical impairment other than mental illness itself. Has to manifest before the age of 22, is likely to continue indefinitely, results in substantial functional limitations, and that's by Ohio Revised Code, that's the definition of developmental disability. It causes the person to need the combination of services that are going to be coordinated, and the SSA is the person who's coordinating those services for that person. So intellectual disability, as you know, used to be mental retardation. That's a diagnosis that's going to be diagnosed before the age of 18. It includes limitations in mental functioning in other areas of life, such as communicating with others, taking care of themselves, and social skills. Up here we have the grid that kind of identifies the IQ that tends to fall within the mild, moderate, severe, profound, and then the proportion of DD population that has that level. So as you see, profound is a very small percentage. And I know you guys have been accepting some folks in the mild range, and on maybe occasion or two a moderate. And we appreciate that help. So for considering the cognitive abilities, we put up here the kind of the pre-operational, concrete operational, formal operational, and the age limits. Talks a little bit about like tailoring the interventions to help support that cognitive ability. So in pre-operational, we're looking at moderate to severe. You guys aren't going to be really seeing anybody in that operational stage. So we're looking more for formal or concrete for you guys. The formal operation we're looking at begins around the age of 12, lasts until adulthood. So that's mild ID to borderline functioning. So at this operational stage, thinking becomes much more sophisticated and advanced. Because we're looking at the pre-concrete and formal operational, they talk about kids. Kids can think about abstracting theoretical concepts and use logic to come up with creative solutions and problems. Skills such as logical thought, deductive reasoning, and systematic planning also emerge during that stage. We also know, though, that when people are in distress, cortex is offline, so they can't really access their ability to reason as well. So we got to calm that limbic system first. Then we can focus on those kinds of skills. Concrete operational then is ages 7 to 11, so we're looking at moderate to mild ID. And here we're developing logical thought. Thinking still tends to be very concrete, so using sarcasm, using that humor, you might want to be careful with that because that could be confusing somebody. They might literally take that. So two other important developments at this stage includes the understanding of reversibility and awareness that actions can be reversed, and the understanding that something changes in shape and appearance and is still the same, so conservation. So those interventions, if you're looking at working with somebody in those stages, would be more likely to see here the formal operation. Avoiding abstract questions, best to have hands-on and visual aids to help support that communication, help facilitate a session whenever you're working with somebody.
Right, so Justin mentioned a little bit ago, I think, that the team members should be able to share with you what a person can do and can't do when they're at baseline. So you're going to work mostly with folks who are mild ID, but when new situations are going to potentially cause them to not show you that they have this ability. So that's why it's so very important when we're looking at, is something related to a mental health symptom or is something related to communication and behavior? What is that person typically capable of doing or learning? And you can get that information from the team.
One of the things that's helpful when we meet in a team environment, because we meet with them, the psychiatrist, the psychologist, the social worker, the nursing staff meet with them in a room together. The visual aids can be very important, and also having paper in there so that they can draw something if they need to. Those things are very helpful. They can draw a face to show you how they're feeling, or we can even have the emotion faces, the charts, where they can point to something and share that, as we were mentioning with communication, to just be able to show you that. We can use those things.
That's great.
Yeah. So some other things that we've known has worked for people who have been in counseling, and we used to have one of the SSAs that used to work in Stark was Chase Harshbarger, and he did a lot of counseling with individuals at Phoenix when he was working there before he became an SSA, and then he decided to go back to being a counselor full-time, and he's back at Phoenix, but he worked a lot with individuals with developmental disabilities, and some of these interventions are things that he's used in his practice. So breathing work, we mentioned the visual and checklist. Using social stories to help people identify unique situations, like what to be expected, what can we see in this activity or this activity that we're going to be doing. Doing physical activities, so getting people up and moving, exercises, tapping also helps work. I don't know if anybody's been trained in tapping here. Collaborative problem solving with the client and direct care staff, so doing some role playing, some meeting with the direct care staff and saying, so this is a situation, how would you handle that? How did you handle that, and what could we have done differently? Keeping the provider, staff, and the SSA in the loop regarding communication, having that feedback, doing a distribution list, making sure people are understanding what's going on and how to best support the person. The Ohio Association of County Boards, that's a group that supports all 88 county boards. They have a program that they call the Good Life, and in their program they have something that's called the must-haves and something that's called the emotional first aid. And these are things that we use when people are in distress. So if somebody's experiencing distress, you give them time to calm down, you give them space, maybe they need a little bit of breathing room. You use positive tones and words, live in their shoes, because we assume that people do well when they can, and that sometimes when challenging behaviors occurs because the demands of the environment are exceeding our ability to help us do well. Being connected is preserving that relationship, making sure that above all we still are a safe person, we still are going to be there to support. Emotional first aid is saying we're doing things that are building trust, that are decreasing fear, that are decreasing emotional and physical harm. We might need to change the environment a little bit, move things out of the way, make sure people are safe, take things off the desk so that they can't hit or throw or hurt themselves or somebody else with, and above all, again, preserving the relationship. There's also EMDR, bilateral stimulation, eye movement desensitization, that I know Chase has used for some folks. It's helped. And Me Moves is an online link there. You can order their program. It's using repetitive movement and music rhythm to kind of help calm the limbic system. And if you go to that link, you can see a demonstration of that. Safety scripts, these are used to help give words to help the people feel safe, and a way to correct and connect behavior to safety. So you say something like, this is a safe place. It's important that no one here hurts you, so it's important that you not hurt somebody else, because this is a safe place. And so then you would repeat that, but you would put in whatever specific thing, you know, maybe if they're hitting or they're biting or whatever that is.
And SSAs may add that to their plans when they're writing the plans. We do try and train them as well to include some kind of language so that staff who are serving the person in their home can provide some consistency throughout.
These particular ones are coming from Finding Hope Consulting, and they are a group that has provided a lot of trauma-informed care training across the state for both mental health and developmental disabilities. And they also have been doing training on the trauma timelines. So they also talk about the 3 Ps, predict, practice, and plan B. So the purpose is to help us decide what might happen and execute a plan, and then to be ready in case that plan doesn't work. So predict, what do you think is going to happen? Practice, describe in detail what they would like to have happen, and then you practice it. And then plan B, have a backup plan in case everything else fails. It's kind of like a social story. Reflect, honor, connect. Again, this is from Finding Hope. Reflect, honor, connect. Reflect back with compassion what you've heard. Honor their courage for surviving and sharing, and connect them with safety and supports. The trauma-informed biographical timelines, as I've mentioned a couple times. Are you guys aware of that? Trauma-informed biographical timelines? Basically, what we're doing in a trauma-informed biographical timeline is we draw a line, a horizontal line. Anything above the line would be positive things that's happened to a person. Anything below the line are negative things that's happened to a person in their life. And you go from birth to whatever age they are now, and then you just kind of track that over time. That also helps develop an ACE score, so you can see what's happened from 0 to 18. And then wherever you see those things, you can connect to what kind of support might be helpful in building the message that maybe they missed as a child. Building your life raft is an activity to help soothe the senses. So you're looking at what do you like to calm yourself? What kind of activities bring you joy, lift you up? What music soothes you? How do you feel a sense of play, and who you're going to call when you need somebody to talk to? So it's just helping identify who is your support that you can connect with. Body mandalas, kind of like, identifying where you're feeling in your body. Using art is another intervention that can be useful, as was already mentioned here. We're focusing on resiliency factors. So we're looking at agency. What opportunities does the individual have to voice their choice and control, and to have power with people? Because in our field, historically, individuals with developmental disabilities don't have power with, people have power over. So we're trying to change that to help them feel more independent, more self-esteem.
That's actually one that I believe causes a lot of distress for our folks, is the power over and the power and control issues that come up in a home. The stressors of a staff who maybe has 3 individuals, has a plan that says this needs to get done, that needs to get done, and then someone's struggling over here. Just like they're human, just like anybody else, but those are issues that come up in the home sometimes, and that could cause a lot of frustration for somebody. We do our best as a county board to support providers to understand that they aren't there to tell people what to do. They're there to help support them. And what does that mean? What's the difference with that? So some providers get it a little more than others.
So building self-esteem, self-worth, how does that individual show that they care about themselves? Are they taking care of their hygiene? Are they dressing nicely? Sense of self. What do they like, dislike? Sometimes people don't even know what they like and dislike because the choices are made for them. So giving them the opportunity to pick, and it might be simple, either or choice at first, because it can be difficult the more choices you have. Self-efficacy. How does the individual affect change, or can they? Can the things that they do create the change that they want? External supports. What are the people, places, things that are important to them, and do they have opportunities to connect to those things? So we're trying to build connections in the community. We're trying to get people integrated into their community a little bit better. Affiliation. Where do people feel a sense of belonging? And then positive, safe adults. Who are those folks that they can turn to when they need to, when they're feeling distressed, and that they know they'll help them? So these are the resiliency factors that we're trying to work on and build for people.
And that's another difficult thing that we look at and try to help with is just like here, you guys are 24/7. So it's 24/7 in a home. So you've got 3 shifts, usually of 8 hours of different staff coming in. It can be very hard for an individual to connect with somebody when that's how it's set up. We do have some situations where we have shared living, which is more of like a family kind of environment. We used to be adult foster care. But that's another issue that can cause a lot of distress for people, is a lack of really being able to connect to a positive, safe adult.
They're basic, go ahead.
I was going to say that you can almost take the information here and use that with our teams for an individual to help build sort of a mini plan for them while they're here, to help them maneuver through their stay here.
Yeah.
Using these questions and working with them.
Great.
Yeah, great. So basically there are 3 kinds of waivers that people might have. Some people might not have them at all. So we have roughly 3,900 folks that we work with. Not all of those have waivers by any means. The waiver is a mechanism that helps pay for services. It's basically paying for staff to help provide services to people. It doesn't pay for housing. It doesn't pay for food. With a couple exceptions, it does pay for home delivered meals at times. There are 3 of them. There's level 1, which goes up to about $5,000. So it's very minimal services if somebody has that. There's the self-waiver, which is kind of a little bit of a mid-range kind of waiver. And then there's the IO, and the IO is the biggest one. And it has funding levels within it. It starts at a little over 5,000, and it goes up to, what, 250? 500,000. And they're going to be adjusting those ranges because they're increasing the DSP, direct service professionals, rate hourly over the next 2 years, so those ranges are going to adjust to accommodate that change.
So you'll have some people potentially who you work with the team and the team says we can do that, we can do that, we can do that. And then you might work with another team who says we don't have the resources to do that because they have a different waiver or a different funding
don't have a
source.
waiver at all.
Or
Yeah.
don't have a waiver at all, yeah.
You're talking that's on an annual basis?
Annual. Mhm.
Yes.
The county board, when you're on a waiver, the county board pays about 47% of that money. The state pays the rest, the federal money.
How do you decide which waiver they get, which level?
Do you want to, yeah, go.
Okay, so level 1 waiver that offers $5,000 of funding a year and also pays for adult day support is something that was that was kind of the first push for, hey, the federal government said, but we'll help out, the 60-40 split. Most people who live with family, they're just coming out of high school, they get a level 1 waiver because they have somebody in their life who's a support for them. They have a place to live. They have someone who gives them whatever level of supervision that they need. But they just need a little bit of support to get out so they're not sitting at home all day long. So that level 1 waiver is a waiver that right now, most folks who are coming out of high school, we do a lot of transition age work with kids because of employment first. So those folks generally get a level 1 waiver. However, if when that person comes known to us is in a crisis situation and they, without support from the county board, would be at serious risk of harm or death, we do have the ability to do an assessment to see if they can get a different waiver. So that would either be a self-waiver or an IO waiver that Justin talked about. We decide which waiver based on the need. So there's an assessment done. The self-waiver was initially created long ago for autism. There was a call for a waiver for all these kids who have autism. And over the years, it kind of shifted, and when it actually became a waiver, it's called self because it's supposed to be self-directed. So more for an individual who is higher functioning, potentially somebody who has physical disabilities but not cognitive disabilities, who can do some of their own hiring. It's just built differently. That waiver has different services. Generally, the folks that you're going to come across are going to have an individual options waiver, that IO waiver. Really, that's the only waiver that allows for the funding needed to support somebody to live in the community if they need more than just drop-in services. So that's basically how it happens. Now, we have another thing going on with our waiting list. For years and years and years, we'd say we put people on a waiting list, and we weren't really able to enroll a lot of people. The state said we have to get rid of that waiting list. There's like 2,000–3,000 people on it. It hardly ever moves. It's just not a good thing. So they created a new assessment. So we as county boards, not just Stark, but every county board across Ohio, has to, within, I believe, 2 years, those 3,900 individuals that we serve all have to have this waiting list assessment. The waiting list assessment was created with, does the person need a waiver in mind, right? So it looks at what are the risks, what are the protective factors, is there something else in the community that could potentially support that person without this Medicaid funding. But that's generally how that happens.
Okay, so additional resources here. This is our contact information. If you ever have any questions, that's the main number, is the 477-5200. Our main offices are out of the Whipple Avenue location. We have the MUI, Major Unusual Incident Hotline number, listed there as well, 477-4477. We have a contracted sheriff's officer, Deputy Betts, who is at Stark DD pretty much every day. Yep. And he does a lot of the criminal investigation. So if there's an incident that's been reported that results in something that is potentially criminal, he's going to be doing those kinds of things. We have a tool on our website for the navigation tool. It's broken up into age groups. So if you have questions about resources and finding services for an individual with intellectual and developmental disabilities, you can check out that tool. The intake number is down here as well. If you have somebody that isn't connected to DD services, but you feel that maybe they should be, if that person's willing or their guardian is willing, you can give them that information and they can contact to check and see if they're eligible for services. As far as intellectual disability resources, here are a few. There's the Association of Intellectual Developmental Disabilities, the ARC, and Center for Parent Information and Resources, and they all have good information related to intellectual disabilities. For autism, there's a number of autism resources. OCALI, Ohio Center of Autism and Low Incidence, they have free online training so you can become trained more specifically on autism spectrum disorders. Milestones is out of Cleveland. They do an annual conference, and while I have never attended it, I've heard nothing but good things about their conference. They are a great resource in connecting people with autism around the state. Fetal alcohol syndrome is another diagnosis that we sometimes encounter.
More and more. It's more and more.
And that's just a link to some support to that. And traumatic brain injury is also another common diagnosis. Again, has to occur before the age of 21 for the traumatic brain injury to be considered eligible for DD services. After that, they wouldn't be eligible for DD services. Finding Hope Consulting's there, Resiliency Project videos. The Warrensville Developmental Center last year hosted a series of trainings about mental health services for the DD population. And all of those resources that they had at that training are listed here. So you see the different topics. They had borderline personality, bipolar, etc. And all of their resources and PowerPoints are on that live binder site. So if you wanted to look for any information there. Our contact information is here. We can talk a little bit about eligibility if you want us to do the eligibility part, or...
We don't have any social workers in here. I think they would benefit the most from it.
Okay.
What do you guys think, Dr. Dumpy, Dr. Kimball?
I think they would.
Social workers?
Mm-hmm. Yeah.
So I have your PowerPoint, and I have sent it out to their supervisor.
Okay.
Maybe she can contact you, and you can maybe do something just for them.
Yeah. Yeah. Questions?
So do you guys have like any resources, because most folks that probably would come here would have the traumatic brain injury after the age of, prior to that 22 cutoff. So do you guys have like resources that would direct us to how do we help this person that entered the door that's not in your system?
Is that place in Akron still there?
I don't know. I haven't had any contact with them.
I don't have anything with me. I do have the name, and I can send it to you if you want, of an organization that's based in Akron that works with people with traumatic brain injury who when it happened past 21. Unfortunately, it's been a big discussion over the years with the board too when that happens, but they've stuck with it needs to happen before 21.
And that's the state that's their criteria.
Right,
it's not local
advice
boards.
board, right.
So all 88 counties are going to be under that guideline. As far as like from behavior support kind of standpoint, there is a behavior support rule that we have to follow, and anybody who is receiving services from the DD board, those people who provide that service must follow that rule. So we can't ask providers to violate that. And that goes even with probate court orders, with doctor orders, with guardian saying, I want you to do these kinds of things. If it's a restrictive measure, that can be a manual, a mechanical, a chemical restraint, a timeout, or any rights violation. So we're taking something away from somebody or not letting them have something that they want. If we do that, we got to make sure that there's either immediate risk of harm, so they're a danger to themselves, they're a danger to somebody else. They're either capable of doing that thing, or they're very likely to begin doing that thing. Or, in the case of the rights restrictions, if there's a risk of legal sanction, so they might be evicted, they might be arrested, that kind of thing, then we can restrict the person's rights in that manner so that they avoid that kind of situation. But absent either risk of harm or likely legal sanction, we can't do anything that would be restrictive of that person. Putting our hands on them. Medications that are used to control behavior has to follow that rule. So if there's a PRN or even any kind of ongoing medication that's just prescribed for behavior, so they're using that for aggression, they're using that for agitation, that would be considered a chemical restraint in the DD system. If it's diagnosed for something in the DSM-5 and they have that diagnosis, it's not a chemical restraint. So sometimes you might get questions about that. If something's written for somebody, they might say, well, is it for anxiety? Is it for whatever? And if so, can we write it for that as opposed to agitation? And then it doesn't consider itself a chemical restraint. In our system, when it's a chemical restraint, we got to take that through the Human Rights Committee. They have to approve it. And if they don't, or it doesn't seem that there's a connection to risk of harm, then there's an unusual incident report that's filled out every time that person gets it. And then the provider has to turn that into the board. Over time, that can create a trend and pattern. The state becomes aware, and then they're asking, what are we doing to not have to do this anymore?
So those are the same rules and regulations we follow here. We have a very robust QA program here that doesn't allow those things to happen.
Good. Good.
No more cigarette schedules for people.
Yeah.
That was a big one.
Because sometimes we do see doctors, not from here, but I mean, we do see doctors, primary care doctors, clinicians, who will say, well, just do this. Just
Don't
take
let
that.
them on the internet.
Yeah.
Or keep them away from sugar, or, yeah. And the system did that for a long time. Our system did that for a long time, but thankfully not anymore.
As far as interventions go, one of the things we do is look at the treatment plans and make sure we are, doing everything we can to meet the needs of our patients. Do you guys have like a sample treatment plan that you could send that has standard interventions that you use that we could maybe utilize as well for some of our patients?
I don't know.
Look at
We can see if
making one.
we could make one. I don't know that we have anything that's...
What we could do is kind of consider some folks that we're aware of that have interventions and kind of rewrite that plan in a more, we could look at doing that for you.
Thank you.
Maybe this was asked, how about consultation on the difficult case if we need somebody to come take a look at the patient, give us some guidance on how to best deal with that patient? Is that available?
Absolutely. The SSA involved is expected to be in contact with Heartland and to be able to come out to see the person. So, yes. We actually, Stephanie Wilson had called me about an individual, one of my SSAs has on their caseload, and the question was, they've been in the emergency room for almost 24, 26 hours. He's still acting the way he's acting. Crisis is trying to figure out, is this mental health or is this behavior? So Stephanie called me and I asked my SSA to go out to the hospital emergency room, which she did. And she spent about an hour there, talked to everybody, talked to him, and knows him really well. And he did not end up going. He didn't end up coming here because she was able to determine that there was something that had happened in the home that agitated him. Here's the things that are different. Here's what we need to put in place. So the provider felt comfortable bringing him back, and he actually ended up going to work the next day. So we've had that happen. We've also had kind of the opposite happen. One of my other SSAs had a gentleman that Stephanie had called me about, and I believe he was at the emergency room as well. And it was the question of what's going on with this person. And so I was able to send the plan. I sent our assessment and our plan and shared with her that although he does have mild ID, his primary struggles are with his mental health. And so he did end up here. So in the last year or so, I say we've really increased our collaboration. And we are absolutely open to doing that. Whatever we can do to make sure the person gets the right service. So Justin and I are on our MIID, or Mental Health Intellectual Disability collaboration with the Mental Health Board. And we've done that for about 10 years. So that is very important to us. We're trying to educate our system too, little by little, about mental illness here in Stark County. The SSAs, we provide them with support too if the person has mental health issues and what that could look like. So.
If anybody here wanted to request a referral for an MIID, you could reach out to Stephanie Kucher over at the Mental Health Recovery Services Board. She's our contact over there for the MIID team. Or you can reach out to Roserai, and you have our contact information out there. And then we just have that meeting to try to balance services for people who are receiving that support in the community.
So you could request like a consultation so that you get the mental health providers and the DD providers at the same table. So we try to have the direct service provider come, the person in the home with the person, case manager. Sometimes we've done a few at Phoenix where the prescribing psychiatrist has been able to pop in for a moment and ask a question or hear some information. So anything we can do to strengthen that too.
Another option is we have a technical assistance team that we can request technical assistance from the state. And it's a team that comes from a developmental center, and they'll come out and they'll review the information. They'll meet with the team. They'll talk about what's going on. They will make recommendations for supports that might be needed. And that might happen even while somebody's in the hospital. And if that does, then they'll ask to see that person if they can. in that setting, so they can kind of meet them and see what's going on. That's been helpful to a number of teams. The developmental centers, I don't know if you're aware of this, they've been closing over the last few years. They used to have one in Youngstown that closed probably a year and a half ago or so.
Well, longer than that.
Was it? Time goes by quick. I
3,
can't
4
believe it's
years.
already.
It's been a long time.
It's almost Christmas now.
Let's see.
So we have a DC that's in Warrensville still, Warrensville, Ohio, and there's one in Cambridge. Those are the two that are probably the closest to us. And usually for that TA assistance, it's coming out of Cambridge. But it's difficult for somebody to get into a developmental center, just like it's difficult for somebody to get into a state hospital. It's less and less likely that they're going to keep people for long term. Usually the stay might be 180 days if it's a stabilization stay, but they want to get people back in the community as quickly as possible. So our resources kind of get limited as far as what we can do to put people in inpatient stay, you know.
When those clients come to our facility, just our environment in general triggers. Because it's a lot of times chaotic, right? I know in the past I've had some, when I worked the floor, an individual would come, and the easiest thing ever was when that plan came here with that client. You know, Stephanie can get those, but if it's Friday and our TPWs are on the floor with this client for a long weekend, we really don't have time to wait for Stephanie to come Tuesday, contact you guys and get that. So if there would be a way we could expedite that.
You can contact us. Anybody from here can contact us.
So that
It doesn't
would be
have to
something
be
internally
Stephanie.
that we would have to come up with. When you get a call for an admission, that should be part of that intake, saying we need that to come with them.
And I think that's great because we're not always aware when one of our individuals is in the hospital and is being considered for Heartland.
So we would
and
have
we
to
want to
call
be.
you.
Yeah.
No,
well,
no. If it's on the weekend or after hours, I would call the MUI hotline, that 477-4477 number. I'd call that because there's always an SSA and there's always an SSA supervisor on call. So I would say, hey, this is the situation, this is what's going on. Can you help us by sending a copy of that plan? And that person should be able to log in remotely, forward a copy to.
and have immediate access.
Yeah.
So,
you
and
guys.
we'll have to talk to the staff who generally do that just to let them know. If you come up with a process, it might be helpful if we discuss that then so that we make sure we know what we're doing on our end.
Yeah.
I think proactively, because these individuals typically go through the emergency room and they have a procedure that is going on before they are referred, before they are accepted to a state hospital, for example. And so I think that is information that will be good for the pre-screener, the community mental health who goes to the emergency room to screen that person, to have that information. Once this person is accepted because they know to Heartland Behavioral Health, and they're sending us the emergency room information and all what was done, that is part of it. That will be even a lot more easier because they will arrive, we have that information and we can implement it, as opposed to that person getting here before we start to call to get that information. Maybe that would be helpful.
We can reach out to Tamika West, who supervises the pre-screeners at Crisis, and see if we can talk about doing something like that.
Because perhaps they need guidelines, just like she said, we have a packet that they send prior to anybody coming in. It's reviewed and all those kind of things. And it would be nice to have that information available on the off chance that they do come here, that, you know, we can start from, like Amy said, from the moment they get here versus waiting days or whatever. Because our environment is chaotic. On admission units, it's very chaotic. And it's probably frightening for them. And we have nothing to go by until, you know.
No, that's a great idea. That's a great idea.
If it's somebody who's connected with the provider, a lot of times the provider will be with them in the ER up to the point where they get admitted, and then they don't get paid anymore by Medicaid, so they step back. But up to that point, if the provider is aware that they're going to be admitted, they could also be supporting by getting that information, because they would have copies of the ISP. They have to have a copy.
So I do consulting work with some of the DD homes in Massillon here, and so one of the first things I do is go into the home, review the ISP or the My Plan, if that's what they have. And some of the information that's right there, even though they're lengthy, and maybe not everyone would have the opportunity to read the entire plan, some of the stuff that's on those first couple of pages, things that upset me and things that I need, are really so valuable.
Glad to hear that.
That to know in our environment, because they may be, some of those things might be outside of the box for us. Because we try to have as a consistent environment as possible across the board. And so some of those things on that plan are going to be out of the box for us. And we need to think those through as a team, how we're going to do maybe something a little bit different for this individual because they're different.
Yeah.
So that's why those plans, I think, are very important from the moment they get here, so that we don't exacerbate their symptoms and cause more problems for them, and then have to reel from that too.
That makes a lot of sense.
How current are the plans, or how often are they updated?
They better be updated as things change. There's always, in the rule, there's an annual review and like the formal assessments that the state tells us we have to do, like self-med assessment. I can't even think of what another assessment, behavior add-on assessment, some of those are done annually. But the rule also says that when there's a change in the person's need, the SSA needs to do whatever assessment would go with that and then make changes to the plan. So it should be up to date, like to today, for the most part. I mean, like within weeks sometimes, but.
And just another thing, I don't know what role you can play in that. We have all these developmental centers that are closing down, the workshops and things like that. And like you say, if there is somebody who has individual support in the home, they go to the emergency room with them. The minute they are admitted to the hospital, the services stop. Meaning that it is an expectation that wherever they are admitted, they pick up from there. Our TPWs who provide the everyday care, they don't have that training. So that link, I don't know how it's going to come, where it can come from. I think it is something that, I don't know if you guys...
It's above my pay grade.
Right.
Well, like that, if you know where we can put our voice or things like that, because you have somebody who's in a home who is on a one-to-one, and that person knows them. The minute they hit the hospital, they say the services stop right there. Right. How can they continue those services in such a way that...
It's a Medicaid thing.
Right.
Yeah, I know. That's what I'm saying. I don't know how much...
So, I mean, one of the things I know when we had our agency in service just, was the last Friday? And Director Davis from DODD came up and spoke to our agency. And one of the things he talked about is something that they're talking about at that level is exactly that. What happens when somebody goes to the hospital and the people that they rely on, that they know they'd have a relationship with, kind of disappear. I mean, the provider can allow their staff to stay. They're just not going to get paid for that. So sometimes providers do that, and it's a cost of doing business kind of thing. Other times providers say, well, if we're not getting paid, we're not going to do that. So it can be hit and miss in that sense right now, but they are talking about that at the state level. So I don't know when we'll see anything, if we'll see any changes to that, but it makes sense to do that. Any other questions?
Do you guys have any questions? You guys are the ones on the front line dealing with this. What do you need? Leon.
their plan, like what you said. You know, that would be really helpful, just to know what works, and, you know, because everyone has different techniques that works for them. So, something like the color, some people want to be isolated, some people, you know, want to talk. It's just like, it's all in the so.
It just seems frustrating, because from what I gather from the interventions that these folks need someone, it's a time-consuming process. And it's just something that we don't have, especially on the units, on the admission units where we have the high acuity things. It's just that unfortunately, I don't have the time to sit and do the picture board or to do any of the other interventions. So as a consequence, a lot of the DD, am I saying it right? Patients just aren't being giving the time or the help that they truly need when they come here. It's just because we are not equipped and just don't have the staff. So it's frustrating.
Sure.
Because more often than not, I see the DD patients starting to decompensate instead of getting the help they deserve, and then it kind of affects the other patients because we're mixing with all type of acuities, and a lot of times it hinders the healing process of the other patients that we have.
Sure.
That are on the unit that can't really adapt. And then you have the patients with mental behaviors. There's abuse that takes place here in terms of the mental abuse and the things, and it's just a very frustrating situation.
I would definitely say too, the weekends are the roughest, because you don't have all of the doctors and all the staff that you normally have like during the week. Like a lot of times on our unit we have nursing student or someone that can kind of sit down more, or if the doctors see them getting frustrated, they can come out more. On the weekends, we don't have that except for the floor staff. And it's very hard, you know, and if we could get, like, say if they're on one-to-one, for that staff member to call into us or even come to the team too, to let the TPWs know, well, this kind of do this, because everyone does things different.
That is something that could happen. You know, that what you're talking about could and should happen. Just to get the information to you, right? Is that what you're talking about? Yeah, so we need to talk about how to make that happen.
Yeah, I think the discussion today has kind of generated some thoughts about how to maybe more from the get-go. So the plan in place, having the SSA or a team member come quickly, you know, to a team meeting, have the TPWs at the table, have, you know, I think there's some things to do to help decrease some of the challenges, although we won't get rid of all of them.
But I can tell you SSAs would be very happy to come to that meeting. They would.
Yeah.
We just need to know who to contact and how to make that happen. But I agree with you. I think it's very important.
I think
for
social
both
work,
sides.
that's why it'd be imperative to have them involved. So.
Yes.
Because they kind of coordinate how
Coordinate all of
we-
that.
Okay.
Yes.
Also, I think another way that we get at that issue that we were talking about a minute ago is with the new MUI rule, anybody who's sitting in a hospital ER for 24 hours, that's an MUI now. So they're going to start collecting data on how often that's happening. It happens more often than we'd like to see it happen. So that might then drive change to how do we help support people with their staff.
Thank you.
Thank you.
Thank you very much.